The time has come where I have the pleasure of introducing this year's winner of the HRB Impact Award. And so now I have to describe this person without completely giving the game away, though I guess you'll probably guess it as I go along. But I mean, first of all, just to remind you what the aim of this award is. I mean, the aim is to recognise the impact, the benefits, the achievements of HRB funded researchers, but beyond the academic, important as that is. So in other words, this could be in terms of improving people's health, advancing practice, informing policy, but ultimately it's about research that delivers better health outcomes and experiences for patients, communities, organisations or society. Now, this is adjudicated independently, and according to our independent adjudication panel, this year's winner received the award for their exceptional influence on policy and practice in the Irish healthcare system and is a role model for impactful research. And as I carry on about their achievements, now you probably start to guess who it is, so I'm going to be fairly brief. The winner is a practitioner as well as a researcher. Collaboration has been a constant feature of their work, including a proactive approach to public and patient involvement. They have had an incredible impact on chronic disease management in primary care, been influential in significant innovations in GP practice that have been implemented nationwide and supported many people to do research that really impacts on the delivery of health services and prioritises the needs of patients. The international standing of this person's work is evidenced by their role in government advisory groups in Germany and Norway, in addition to their national recognition of their work and positions of policy influence at home. So after all that, I guess you know who it is. The winner probably needs no introduction. I'm delighted to announce that the winner of the 2025 HRB Impact Award is Andrew Murphy. And in case anybody doesn't know, Andrew is Professor of General Practice at the University of Galway. He's a GP in Turloughmore, County Galway, and Director of the HRB Primary Care Cancer Trials Network in Ireland. So, Andrew, it is a pleasure to present you with the award. Let me come over here. I'm just going to hand over to Andrew now and invite him to say a few words to accept his speech.
Thank you very much indeed, Mairead. It is actually very rare for me to be short of words. However, I am genuinely humbled to receive this most prestigious award. I very much accept this nomination on behalf of all the outstanding colleagues from the many different disciplines with whom it has been my privilege to work. And if we can start the presentation, please. I'm going to talk about the power of the 3 Ps: patients, people, and papers. And perhaps if we could get the presentation on the slide, on the projector in front of me as well. Possibly the most impactful meeting I have ever attended, obviously secondary to this one today, was in 1998 in London. It was the 50-year anniversary of the publication of the first ever randomized clinical trial in the BMJ. This famous trial involved the randomization of 107 patients whose tuberculosis was considered too severe for usual treatment of bed rest at that time. 55 were randomized to the wonder drug streptomycin and 52 to usual care. The simple outcome was death at 6 months. 7% of people randomized to streptomycin died, 27% died from the usual care. This finding was significant at the 0.01 level, and I believe that the management of tuberculosis was certainly changed forever, but probably even more importantly, the clinical research paradigm was absolutely transformed. I think there's a lovely arc to this afternoon's talks, from Connor talking about the future of randomized clinical trials, and we're going back all the way to 1948. And why in God's name am I doing this? It's because how can we measure cause and effect? Hidden away in the authorship there is Austin Bradford Hill, who is the father of causation. In 1964, he achieved fame with his explication of the criteria for causation. And so to my disclaimer. Health services research does not equate linearly to streptomycin and death. I am only too aware how complex an ecosystem medical practice and quality is. Clearly, there are very many actors in supporting the translation of research activity. What this nomination demonstrates, I hope, is the focal and sustained role which I've attempted to play in harnessing HRB funding to produce open access research, which in turn highlights the potential of Irish general practice. I have then utilised a multimodal advocacy approach with my peers, professional organisations, and crucially, government advisory groups as an avenue to impact. Having said all that, I'm still not sure if Bradford Hill would give me a pass mark. This is what I wish to discuss. It highlights, I think, the non-linear pathways which I've followed, with as many precipitous snakes as helpful ladders. My deceased father left his mark on me, quite literally. This photograph, taken on the golden waters of Lough Swilly in Donegal, is infamous in my family for being the first one taken after my older brother Philip, then aged 8 years of age, had been given responsibility by my father for a starting cannon in yacht races. I, aged 4, asked Philip's best friend Brendan, "What comes out of a cannon, Brendan?" And Brendan looked at me and said, "Well, I don't know. Why don't you look down it and find out?" and wandered away. So Philip, my brother, was looking at my father, who was looking at his watch, who said fire, and I was looking down the snout of a cannon. What this photograph showed before it faded was the bright blue gunpowder fragments that were littered all over my face. I personally think that my primary school nickname of Gunpowder Murphy was quite unoriginal. Another more permanent mark he left in me was the importance of high-quality evidence. He qualified as a doctor from RCSI, and this is his clinical notebook from November 1944, opened on the page of heart attacks. There are 3 key lessons to be learned from this notebook. Firstly, the standard of medical handwriting has improved remarkably over the years. Regarding clinical content, his description of the symptoms and signs of a heart attack would stand solid with anything taught in any medical school today. Tragically, regarding management, the range of interventions is pitifully small and weak. I quote from the management section here, which I've outlined in red. Treatment, complete rest in bed. NB, patients should be moved as little as possible. A minimum of 6 weeks, longer in a bad case. Tragically, within 20 years, my father's father, whom I never met, received this exact treatment for his massive heart attack, and he died, as so many others did, of massive lung clots at around 2 weeks. This is not to criticise those who implement best care, but to behove us all to always seek better care. My father was only too aware of this. He specialised in tuberculosis and well remembered the advent of streptomycin a few years later into the Welsh valleys and the impact that it had on the Welsh miners whom he was treating. Poor quality evidence at best wastes resources. At worst, it kills, as it did to my grandfather. The sustained work that the HRB does in supporting the production of such high-quality evidence is, to my mind, priceless and does not get the recognition that it deserves. I repeat, I very much accept this nomination on behalf of all the outstanding colleagues in the many disciplines with whom it has been my privilege to work. These include colleagues from general practice, health psychology, health economics, biostatistics, nursing, allied health professionals, and many other medical disciplines. I wish to warmly acknowledge the collaboration for over 20 years with Molly Byrne, health psychologist, and Susan Smith, general practitioner, who are both here today. I would not be here today if it were without them. One of the best decisions I ever made was to join Turloughmore Medical Practice. I'm delighted that senior partner Eamon Toomey is here today. This is my favourite picture of the practice, Tuesday, February 23rd, 2021, around 8 p.m. It's just after we completed our first ever COVID vaccination clinic. I like to think that the exhilaration that we felt then was similar to that of my father giving streptomycin in Welsh valleys. We even made the page of the local Galway Advertiser. Turloughmore has ensured that my research is grounded and relevant to real-world practice, and I know that Eamon would say mostly. This slide illustrates the initial approach which I had to a clinical academic career, complete in co-ed chaos. I simply thought it was all about the papers, as was said already, publish or perish. And then I recognized the importance of working with outstanding colleagues on a long-term basis. And only when I really came to Turloughmore did I really get it. Patients. The key priority for health services research is patients. I've illustrated each of the key research areas I wish to discuss with a patient exemplar from Turloughmore. In red in the patient profiles are the key research items under discussion. Here for Mrs. SM, it is cardiovascular disease. There's talk of grand slams at the moment. Mrs. SM achieved the unusual grand slam in health services research. She participated in cross-sectional, cohort, randomized and systematic trials. She always used to ask me with that quizzical smile that I think you can see in her face, "Well, Andrew, how's the old research going for you?" A very young Molly Byrne came to Galway in 2000 to conduct a HRB-sponsored PhD on the psychological aspects of cardiovascular disease, where the research has been funded by the HRB, I've indicated with their logo. I still have no idea of what half of Molly's research referred to, but crucially she completed a cross-sectional study of the prevalence of cardiovascular disease amongst 1,500 patients from 36 randomised Irish practices. Ireland then had money to spend and had just published a report called Building Healthier Hearts, which outlined a strategic approach to the management of cardiovascular disease. I was fortunate to be appointed as the sole GP to the advisory forum tasked with strategy implementation, and I chaired the primary care subgroup. A key priority was to resource general practice to conduct secondary cardiac prevention, namely approaches which reduce the risk of a heart attack or stroke amongst people who already have cardiovascular disease. If you're going to get a budget, you must have an estimate, and that's where Molly's work came in. She had the only available Irish prevalence figures for cardiovascular disease, 3%, half of whom had angina only. We did not have enough money to pay for 3%, so out went the patients with angina only for no good clinical reason, and we now had a budget and we had a programme. Working closely with Michael Boland of the ICGP, HeartWatch was developed. This was Ireland's first universally accessible chronic disease management programme. Subsequent evaluations confirmed that HeartWatch significantly improved patients' lifestyles and key markers such as blood pressure and cholesterol. However, HeartWatch by definition was not at the level of evidence required by Bradford Hill. We required a trial. And in stepped the HRB with a pivotal €1 million programme grant award in 2002. This supported the all-island sphere randomised controlled trial of cardiac prevention in general practice. It was a watershed study, being the largest study ever conducted in Irish general practice, 903 patients from 48 practices, with a resultant British Medical Journal publication. Its key finding was that intensive structured general practice care over 18 months to patients with established heart disease significantly reduced hospital admissions from 34% to 26%, an absolute reduction of 8%, a number needed to treat of 12. But was it cost effective? Our great health economists Eamon O'Shea and PhD student Paddy Gillespie, then PhD student, were able to confirm that the savings of the sphere intervention for each patient enrolled was €512, a medical intervention that saves money. I well remember discussing with Mrs. SM the results of Sphere, in which she participated. I told her that I was disappointed that the trial had not reduced deaths, which was the primary outcome measurement. She looked at me and said, "But Andrew, I'm no longer interested in life or death. I simply want to live better out of hospital." This is the great team that worked on Sphere from north and south of the border. Without knowing it, we had established an all-island multidisciplinary health services research team who would collaborate together over the next 20 years. Susan, Molly, Margaret, John Newell and Eamon O'Shea, who were not pictured here, and Paddy would all go on to become full professors in their cognate disciplines. You can also judge from this photograph for Susan, Molly and I, who has time been kinder to. Bradford Hill would then say, "You've only one trial, you need more than that." A great colleague, Adele Murphy, present in the room too, conducted a seminal 2015 systematic review of primary care organisational interventions like Sphere for the secondary prevention of heart disease in general practice. The results were crystal clear. I've outlined them in red here. Secondary cardiac prevention in general practice reduces deaths by 21% for at least 6 years. If this was a drug, we would bottle it. But by this stage, the Celtic Tiger was no more, and the planned rollout of HeartWatch to all practices had stopped, and indeed was then completely terminated. Thankfully, the Irish economy is powered forward, and since 2020, Ireland has had a National Chronic Disease Management Programme, CDM, of which the secondary management of cardiac disease is a key component, and it contains all the elements originally espoused by the Sphere trial. Repeated evaluations of the CDM programme confirm improvements in all modifiable risk markers. These are the latest national figures. I'll put up for each aspect these latest updates. Let's turn now to access to healthcare, specifically access to GP care. Mrs. MN has a most significant and unusual morbidity, but she still manages to get the most out of life, as I think you can see from this picture. As a daily swimmer in Lough Corrib, it is very easy for me to evaluate her current health status. More than 50 strokes, all is good. Between 20 and 50, increase the medications. Below that, let's consider admission. Last year, Mrs. MN attended the practice 31 times for her significant morbidity. All these GP visits were free. This would not have been the case 5 years ago. Mark has emphasised repeatedly the importance of cross-border, all-island studies, and I could not agree more. And the HRB had excellent cross-border specific funding tracks. And a 2009 HRB cross-border study led by Dermot O'Reilly, now sadly deceased, and myself, quantified in comparison to Northern Ireland the inequitable consequences of the then GMS eligibility to a GP by income only. It showed that over a quarter of fee-paying patients in the graph on the extreme right, as you look at it, had not consulted a GP in the south of Ireland in the previous year due to cost. The equivalent figure in the north was 1%. I repeat, 25% versus 1%. And this disparity was at most stark for females of childbearing years. A secondary analysis by Margaret Couples of Queen's of the Sphere study that I mentioned before compared the management of cardiovascular disease north and south of the border in general practice. It found that blood pressure and cholesterol management were much better managed in the Northern Ireland, which was free at the point of delivery. In 2009, a ministerial expert group on resource allocation and financing the health sector was established. As the sole GP member, I was able to highlight the data we've just seen and champion a proposal to expand GP access. This approach was a key recommendation of the group that I have highlighted there. However, we made two big mistakes, one minor, one major. The minor mistake, and I'll be in trouble for this, was that because we had so many health economists, our recommendations were very complex. They were very equitable, but they were very complex based on income. The major mistake we made was releasing our findings in the year 2010 at the height of the crash, when nobody was interested in expanding access. But with increased public spending, free GP care to all citizens aged over 70 years and under 8 years is now in place, facilitating Mrs. MN being able to attend the practice without any concerns about cost. Now moving from chronic to acute cardiovascular disease, indeed the most acute of all, cardiac arrest. Cardiac arrest is a very heterogeneous condition, making comparative research challenging. A subgroup of patients, those who have a witnessed arrest and have an initially shockable rhythm, are those with the highest chance of survival. This group is known as the Utstein group, after the Swedish island where this definition was agreed. Thankfully, Mrs. A.W. suffered an Utstein arrest and was successfully resuscitated and has been with us for the last 20 years. With Siobhan Masterson and Martin Quinn playing crucial roles, Ireland has gradually developed an out-of-hospital cardiac arrest registry, with myself as lead GP academic. Originally based solely in the old Northwestern Health Board surrounding Lough Swilly, we achieved national coverage in 2012. Ireland is only the 4th country in the world to have done so. Importantly, results from the registry are fed back to all regional ambulance services on a quarterly basis to support quality improvement. Utilising OCR data, the registry data, Thomas Barry, who's again in the audience today of UCD, has recently published a number of national time series studies from 2012 to 2020 inclusive, showing significant and incrementally increasing survival rates over time. Just published last month are these results for the Utstein group itself. You can see there in the blue columns the numbers of survivors. In the orange line, the increase in proportion of survivors in the Utstein group from 20% in 2012 to 28% in 2020. And I should say the 2020 figures were obviously negatively impacted globally by COVID. Our results show that survival to hospital discharge has significantly increased for this Utstein group. And Ireland, as a comparatively very rural group, compares very well to our European average of 28%. Clearly, a huge number of individuals have contributed to these improving figures. Crucially, the public, through early access, early CPR, early defib, the ambulance crews themselves, and then associated hospital staff. But we do like to think that the continuous quality improvement initiatives of the registry have also contributed. And these are the latest figures for 2023, which are the highest yet, and these are the total resuscitation attempts. Stepping back a little bit, how did all this research start to get funded? What was the impetus? What contributed, I believe, was a positive policy decision made by the HRB many years earlier. Tom O'Dowd and I worked together to convince Ruth Barrington, then CEO of the HRB, to commission the 2006 MANT report, Primary Care R&D in Ireland. I think every neuron in Ruth's head was screaming at her, do not get involved in special cases. To be fair, she listened very carefully to our points, and this report was the result. David Mant was the Professor of General Practice at the University of Oxford who had published a similar report for the UK. It transformed the UK general practice research landscape and positioned it to be a global research leader in such research. This Irish report by him highlighted both the core importance of primary care research and that we were underperforming in this arena compared to equivalent European countries. It made a number of explicit recommendations to change this, including the successful establishment of a primary care research centre, subsequently led by Tom Fahey of RCSI, who's in the room again. This in turn provided the impetus for Susan Smith and I to co-lead in 2015 an all-island consortium to establish the HRB Primary Care Clinical Trials Network. Over the subsequent 5 years, the network supported 29 studies, including 20 registered trials, recruited almost 4,000 patients and leveraged funds of over 9 million. With Adele Murphy again in the vanguard, it played a prominent role in the promotion of public and patient involvement in research, for which the HRB has done so much good. In particular, Adele led on the commissioning of a documentary-length and high-quality film on PPI in research, which is available on YouTube, The Patient Effect. Mairead, have I permission to ruminate or even ventilate? There is no holy grail, I believe, to ensure that research impacts on clinical practice and policy. My simple conclusions are, as these examples highlight, it takes a lot of time. Persistence is key. Multidisciplinary work is a two-way process. You have to give in order to receive. Time is the most precious of academic resources. And yes, maybe I said yes to too many projects from too many colleagues. As a result, my CV is snakes and ladders rather than a graceful ascending arc. But particularly in small disciplines in underfunded universities, do we have any other choice? Leveraging research funding to fulfill your clinical interests is one way of doing it. I was fortunate that I had the opportunity to participate in key government advisory groups who were taken seriously and made a difference. It is vital that such national policy-making opportunities continue to be available to colleagues. Experts matter. In today's world, do I sound nostalgic in stating that? There are two additional areas I wish to comment on, and I know from the publicly available minutes of the HRB board that the HRB shares these concerns. The vast majority of health services research is very low risk. With Sphere and other studies like that, the worst outcome that we could have had would be that we would have wasted the precious time of patients and clinicians, and I do not say that lightly. Yet too often health services research has the same research governance in terms of data protection, safety and contractual expectations as a trial utilising the latest experimental cell therapy. This is quite simply bonkers. The increasing corporatisation of universities, I believe, feeds this development. It is really important that the HRB continues to promote and support health services research. And I therefore very much welcome the recent announcement of the revised and rolling HRB DIFA, or now renamed ILCT Awards. Implementation of the MANT report in the UK, which I referred to previously, was possible due to annual NHS ring-fenced research funding with an emphasis on health services research. The HRB has spent over the last 5 years 25% of its budget of £235 million on research infrastructure, such as the primary care network. This is wrong and possibly unsustainable for the HRB to shoulder this burden alone. Co-funding of key clinical research infrastructure by the HRB and crucially the HSE is ideally what we should all be aiming for. The editor of the BMJ recently concluded that globally academic medicine is broken. Key challenges include misalignments between academic and health systems, misalignments and drivers of scientific agendas, and gaps and glass ceilings in academic careers. This is true not just for medical careers, but for all clinical disciplines upon which so much of sláinte care depends. Please indulge me by letting me note how these challenges are exacerbated in my own discipline. Unfortunately, academic general practice has not achieved parity in terms of career pathways or resourcing with other medical disciplines. Introduction of the new consultant contracts only exacerbate these disparities. Of course, the HRB is not responsible for academic careers. However, as a key and prominent stakeholder, I think it important that the board continues to highlight these concerns. Let's finish by looking positively to the future, to our three Ps, and we know now to begin with patients. Patients will have a really enhanced role in research. Laura O'Connor of the Primary Care Network gives us a glimpse of what this will look like. Together with the UK James Lind Alliance, she led a process in which patients and their carers, researchers were specifically excluded from them. And this is the final bit of that jigsaw of the consensus pictured here. So patients and their carers decided what are the top 10 priorities for research in chronic disease management. Number one on their list was, how can exchange of information be improved between specialist hospital services and primary care for both people with chronic conditions and healthcare professionals? I could not agree more. The full list is available on our website or on this QR code. I entreat the HRB to include this and other priority-setting outcomes in their funding calls. The health service research leaders of the future are much better trained, resourced, and internationally connected than I was. Implementation as we've heard so clearly from Laura Keyes, in particular, will provide them with a much better chance of influencing practice and policy. These pictures illustrate the recent PhD graduates of the HRB Collaborative Doctoral Awards, led respectively by Molly in Chronic Disease Prevention and Susan in Multimorbidity. It was a pleasure and a privilege for me to act as co-director in each. It is really important that these high-quality graduates have appropriate career and research funding structures to act as ladders rather than snakes. And finally, the research itself. There's one thing I'm sure of for the year 2050, that the host for these awards will continue to be the Trina Pan-like Mairead O'Driscoll of the HRB. I'm also clear that the recipient of the award will be an academic GP. Her work will be derived from an IT infrastructure jointly supported by the HRB and HSE. This draft schema, developed by the Primary Care Network, illustrates how a template for such infrastructure would work, ensuring safe data collection, safe people and safe projects, together with linkages to other Irish clinical databases and international research initiatives. And apologies to Laura Whelan that I didn't put up genomics as one of the linkages here. There are no IT blockages. This could happen tomorrow. In Turloughmore, we have been paperless for over 15 years. The only paper that we touch is Connor's discharge notes, which thankfully are now beginning to come in automated as well. The only blockage to having this is governance and funding. And against her explicit wishes, I will now thank Marion, my partner for nigh on 40 years, who's somewhere in the shadows, for her unstinting support and belief in me. I still remember her in the then library at Earlsford Terrace in December 1995, seeking out the last paper references for my MD. Heavily pregnant with her eldest son, Ben, she was on her knees pulling a binder out from the shelf and unable to stand up unaided. She said, "Andrew, no more." But there has been a lot more. Michael Harding wrote, "For me to notice that the night is never so dark as to warrant despair, and that the light of heaven is hidden in every shadow, if only I could see it." Thank you, Marion, for always letting me see the light through the shadows. It has indeed been a privilege and a pleasure to have worked with so many of you over the years and to present this corpus to you today. I do hope that we have done some good. Thank you to the HRB for this award and to you for listening. Thank you.